New Low Back Pain Guidelines, the American College of Physicians Update. Although patients with low back pain generally improve rapidly in the first month, up to 33% of patients report persistent back pain of at least moderate intensity for 1 year after an acute episode, and 20% of patients report substantial limitations in activity. As a response to these frustrating statistics, attempts to determine the best type of care for acute and chronic low back pain have resulted in a plethora of studies which include RCTs and systematic reviews. Groups such as the American College of Physicians, among others, try to synthesize this data into generalized guidelines for clinical use. The difficulty, of course, is the vastness of the literature, the complexity of not just the studies themselves, but the rating approaches by reviewers, the heterogeneous nature of both low back pain and its various treatment approaches. Yet attempts are necessary to provide practitioners with summaries of the current scientific literature. You may recall the excitement centered around the 2007 American College of Physicians Low Back Pain Guidelines when manipulation was listed as one of the treatment approaches with evidence. This was important given most physicians were unaware that research had been performed or that there was any evidence for its use with low back pain. In February of 2017, the ACP presented its new updated guidelines attempting to include any newer evidence and including some approaches not yet reviewed. For practitioners and patients, there is a dilemma, though. When only high-level studies are included, meaning RCTs and systematic reviews, other valuable studies, such as prospective non-randomized studies, are not included. And think of the difficulty in approaching this topic. What is the therapy compared to? Is that comparison valuable if the comparison has itself little evidence or equivocal evidence? What if the comparison is placebo, given placebo has its own strong record of effect? Are the effects considered alone for that therapy, or are they only comparisons to other approaches, meaning looking only for mean differences between groups rather than the effect rate for that therapy? And finally, and most importantly, if there is weak to moderate evidence for a given treatment approach, but other approaches show similar effects, how do you make recommendations? Before we review the new ACP guidelines for back pain, it's important to note that no therapy reviewed had high-quality evidence using the rating scheme of this group. And as we will see, those approaches that do have evidence have limitations with regard to benefit. In other words, the treatment might be good for pain but not function, may have a short-term effect but no long-term effect, or may not substantially outperform a sham treatment or placebo. Now to the guidelines. So here's the title, Non-Invasive Treatments for Acute, Subacute, and Chronic Low Back Pain, a Clinical Practice Guideline from the American College of Physicians, published in the Annals of Internal Medicine in February of 2017. It's important to understand that these guidelines are a synthesis of several resources, including the studies from the prior 2007 ACP guideline and 2 reviews published in the same issue as the 2017 guidelines on pharmacologic and non-pharmacologic approaches, both by Chow et al. One of the 2 reviews is Systemic Pharmacologic Therapies for Low Back Pain. The other is Non-Pharmacologic Therapies for Low Back Pain. So what are they trying to accomplish? The purpose of the ACP guidelines, as per their statement, is, quote, to provide treatment guidance based on the efficacy, comparative effectiveness, and safety of non-invasive pharmacologic and non-pharmacologic treatments for acute, subacute, and chronic low back pain. It serves as a partial update of the 2007 ACP guidelines. Let's look at the study population. They included, as usual, adults 18 years and older with acute, subacute, or chronic non-radicular low back pain, radicular low back pain, or symptomatic spinal stenosis. The focus was non-surgical, with a comparison between and among approaches. For pharmacologic, they included acetaminophen, NSAIDs, opioids, skeletal muscle relaxants, benzodiazepines, antidepressants, anti-seizure medications, and systemic corticosteroids. For non-pharmacologic, they included multidisciplinary rehabilitation, spinal manipulation, acupuncture, massage, various forms of exercise including motor control exercise, Pilates, Tai Chi, and yoga, and related therapies including various physical modalities. It's important to see how reviewers rated treatment effect sizes when comparing differences between therapy groups. When looking at pain, it was based on either a 10-point or 100-point pain scale, and for function, it was either the Oswestry or the Roland-Morris Disability Questionnaires. For pain, a small effect was between 5 to 10 points on a 100-point scale and between 0.5 to 1 point on a 10-point scale. A moderate effect was greater than 10 to 20 on a 100-point scale or greater than 1 to 2 on a 10-point scale. For function, a small effect was 5 to 10 points on the Oswestry and 1 to 2 points on the Roland-Morris. And for moderate effect, it was greater than 10 to 20 on the Oswestry and greater than 2 to 5 on the Roland-Morris. Let's review some results before looking at the ACP recommendations. There are some surprising findings with regard to medication. For acute low back pain, NSAIDs were associated with a small improvement in pain intensity compared with placebo. There was no difference between acetaminophen and placebo for pain intensity or function through 4 weeks, or between acetaminophen and NSAIDs for pain intensity or likelihood of experiencing global improvement at 3 weeks or earlier. Skeletal muscle relaxants improved short-term pain compared to placebo at 2 to 4 and 5 to 7 days, and there was no difference in pain or function between a single intramuscular injection of methylprednisolone or a 5-day course of prednisolone compared with placebo in patients with acute low back pain. And for chronic low back pain, NSAIDs were associated with small to moderate pain improvement compared with placebo. Titrazepam, a benzodiazepine similar to Valium, improved pain relief at 5 to 7 and 10 to 14 days compared with placebo, and there was no difference in pain relief between systemic corticosteroids and placebo, and the evidence comparing skeletal muscle relaxants versus placebo was insufficient. Additionally, strong opioids were associated with a small short-term improvement in pain scores, but only 1 point on a 10-point scale. There was no difference in pain between tricyclic antidepressants or selective serotonin reuptake inhibitors versus placebo, and no difference between diazepam, which is Valium, and placebo for function at 1 week through 1 year. Now to non-manipulative, non-medication approaches for acute, subacute low back pain. There was no difference between exercise therapy and usual care for pain or function in patients with acute or subacute pain. The acupuncture response was a small decrease in pain intensity compared with sham acupuncture. Massage moderately improved short-term pain and function compared with sham therapy for subacute low back pain. A heat wrap moderately improved pain relief and disability compared with placebo. And for combination therapy, a combination of heat plus exercise provided greater pain relief and improved Roland-Morris scores at 7 days compared with exercise alone in patients with acute pain. A combination of low-level laser therapy and NSAIDs decreased pain intensity and resulted in a moderate improvement in function. And for chronic low back pain, let's begin with exercise approaches. Exercise resulted in a small improvement in pain relief and function compared with no exercise, and Pilates resulted in small or no clear effects on pain and no clear effects on function compared with usual care plus physical activity. Also, Tai Chi had a moderate effect on pain and a small effect on function. Yoga improved pain and function by a moderate amount compared with usual care and by a small amount compared with education. Motor control exercise had a moderate effect on pain and small effect on function, and motor control exercise, Tai Chi, and yoga were favored over general exercise. And for other approaches, progressive relaxation therapy moderately improved pain intensity, biofeedback training moderately decreased pain intensity compared with weightless controls, and operant therapy, which is behavioral therapy involving reinforcement, slightly improved pain intensity compared to a weightless control. Multidisciplinary rehabilitation moderately reduced short-term and slightly reduced long-term pain intensity and disability compared with usual care, and acupuncture was associated with a moderate improvement in pain relief immediately after treatment and up to 12 weeks later compared with sham acupuncture. Massage improved short-term pain relief and function compared with other interventions, and a combination of massage plus other interventions such as exercise and education, or usual care was superior to the other intervention alone for short-term pain relief. Specifically, let's look at the evidence for manipulation in chronic low back pain. There was no difference in pain with spinal manipulation versus sham manipulation at 1 month. Spinal manipulation slightly improved pain compared with an inert treatment, and moderate quality evidence showed no clear differences in pain or function compared with another active intervention. A combination of spinal manipulation with another active treatment resulted in greater pain relief and improved function at 1, 3, and 12 months. Let me present to you some interesting observations regarding the evidence for manipulation in the reviews and the ACP guidelines. Some of the RCTs and systematic reviews were from the old guidelines of 2007, and they included studies from as early as the 1970s through the 1990s, and only a few newer studies were included. Some of the studies were on osteopathic or PT manipulation. As stated earlier, a number of high-quality prospective studies were not included due to the restrictive parameters of the search and review of these guidelines. And finally, for radicular low back pain, exercise resulted in small improvements in pain and function compared with usual care or no exercise, and there were no clear differences between traction and other active treatments. Given this as an update, what are the differences between the 2007 review and the current review? The 2007 review concluded that acetaminophen was effective for acute low back pain. This update included a placebo-controlled RCT in patients with low back pain that showed no difference in effectiveness between acetaminophen and placebo. Added was evidence for mindfulness-based stress reduction, motor control exercise, taping, and Tai Chi. The evidence for taping showed that there was no difference between sham versus kinesiologic taping. Superficial heat was found to be more effective for acute or subacute low back pain, and neither ultrasound nor TENS was shown to be effective compared with controls. Now let's review the recommendations. Recommendation number 1 for acute low back pain was a strong recommendation. Quote, clinicians and patients should select non-pharmacologic treatment with superficial heat, massage, acupuncture, or spinal manipulation. If pharmacologic treatment is desired, clinicians and patients should select nonsteroidal anti-inflammatory drugs or skeletal muscle relaxants. Recommendation number 2 for chronic low back pain is a strong recommendation. Quote, clinicians and patients should initially select non-pharmacologic treatment with exercise, multidisciplinary rehabilitation, acupuncture, mindfulness-based stress reduction, Tai Chi, yoga, motor control exercise, progressive relaxation, electromyography biofeedback, low-level laser therapy, operant therapy, cognitive behavioral therapy, or spinal manipulation. And for recommendation number 3, for chronic low back pain patients non-responsive to non-pharmacologic approaches, there is a weak recommendation. Quote, clinicians and patients should consider pharmacologic treatments with nonsteroidal anti-inflammatory drugs as first-line therapy, or tramadol or duloxetine, which is Cymbalta, as second-line therapy. Clinicians should only consider opioids as an option in patients who have failed the aforementioned treatments, unquote. And now the take-home points. Although there is only weak to moderate evidence when reviewing high-level RCTs and systematic reviews, non-pharmacologic approaches seem as effective as pharmacologic approaches. Several new approaches, or more correctly, evidence for these approaches, demonstrates an expanded menu of choice for patients and doctors, including for acute low back pain, superficial heat, massage, acupuncture, manipulation, and NSAIDs. And for chronic low back pain, multidisciplinary rehabilitation, Tai Chi, yoga, Pilates, most forms of exercise, low-level laser, acupuncture, mindfulness, biofeedback, behavioral training, and manipulation.